with a positivity rate of close to about 10%. In Texas Medical Center, our hospitalizations are up 90% over that same period. And our positivity rate is now climbing to 6%. We are clearly seeing the beginning of the fourth wave of this pandemic, which is alarming at best. I want to turn to Dr. Klopman now to share with us a little bit about what we're seeing, and particularly with the Delta variant and its impact.
Thanks for inviting me. This is clearly the result of the emergence of the Delta variant as the dominant variant in the United States. And this happened in the United Kingdom as well. The Delta variant emerged in India. There's actually several different mutations that are lumped together as the Delta variant. And it's very similar to the UK variant with a few other amino acids, some of the nucleotides in the spike protein that's a little bit different. And it makes it more infectious and potentially more virulent. So, virulent in terms of causing disease. The United Kingdom has the best data, and what they showed was the original Wuhan virus, or the European virus that came in through Italy. That virus has a 0.5% case fatality rate. The UK virus was 0.9%, and the Delta virus is at 1.1%. So it's not only more infectious, it causes more disease and it causes more death. So it's a very it's a disturbing variant of this virus. 8 weeks ago, it was a very small percentage of what was in the US. Now it's between 60 and 70% of what's circulating. And the interesting thing about the Delta virus, it is significant, it is enough different that the monoclonal antibodies, for example, that were effective infusions against early disease before with the UK variant, these are no longer effective against the Delta variant. The good news, and it's great news for us, is the mRNA vaccines, Pfizer and Moderna, and Johnson & Johnson are effective at neutralizing this virus. It's not as effective as for the UK virus. There's about an 85% effectiveness in terms of preventing serious disease with the RNA viruses, with the mRNA vaccines. So it is what is going on now in our community is really the people who are not vaccinated are totally susceptible. It's a more infectious and more virulent virus. And so that's who's getting infected. The vast majority of people in the United States who are getting infected are folks who have not been vaccinated. There are some breakthroughs, but it's a relatively small amount, in between 5 and 15%. But the people who are dying, as our Surgeon General said the other day, 99.5% of the deaths from coronavirus remain in people who have not been vaccinated. So the best news is the vaccines are still effective, and people who aren't vaccinated are still very, very susceptible to the Delta virus.
And Clement, can you talk a little bit about breakthrough? We're hearing a lot about breakthrough in the number of people that may be vaccinated from the Moderna, Pfizer, J&J here in the United States. And yet we're hearing about breakthroughs. Can you share the concept and what that means?
So a breakthrough is when you've been fully vaccinated and still get infected. And all of these, every vaccine is, none of the vaccines are 100% effective. There's always some group of people who, for whatever reason, either they don't generate enough of an antibody level, don't have enough of a response to the vaccine, that just, they're not fully protected. And so we anticipate, even if it says, 95% effective, that means 5% of the people are going to be infected, even though they've been vaccinated. I'm sure this has happened to people with flu vaccine, where they've gotten vaccinated, they're 60% effective, and then someone contracts the flu. The good news is that it's a much reduced disease process, and it protects you from being for serious hospitalizations and death. I mean, that's the real key. But there are still people who get admitted to hospitals who have been vaccinated. Now, it's a very small number so far recorded in the US. There's been something like 5,000 admissions to hospitals of people who've been fully vaccinated, compared to the millions of people who have been vaccinated. So it does happen rarely, and there have even been an occasional death. But if you go back and look at who those people are, they often have underlying disease, cancer, diabetes, transplant patients, immunosuppressed patients. So, the main thing is these vaccines are incredibly effective, much more so than many other vaccines, and the risk profiles are compared to their benefit are just really, people should be trying to get vaccinated as soon as they can.
I remember back a year ago when we were looking at major events like 4th of July was a major event in COVID. And what we've seen here in the medical center, which has been represented well around the world, is after a lot of people come together without public health efforts of wearing masks, we saw 2 weeks later a huge surge in our hospitals. Dr. Hotez, share with us, many things have happened since COVID and now the relaxing of public health, mask wearing and mandatory mask wearing. What are you seeing you've been at the forefront of this from the very beginning. What are you seeing now with this Delta variant? You're muted, Dr. Hotez.
Yeah, sorry. Yeah, the way I think about this is I try to bring it back to first principles and think about it from the virus perspective. And, we're still learning about the Delta variant, as Dr. Klopman points out. There is this very interesting, it's not even a preprint, it's up on a discussion group called virological.org. So I'm a little reluctant to get too far over my skis on this, but it's written in the form of a paper by a group out of southern China that looks pretty credible, out of Guangdong, the Guangdong Centers for Disease Control. And what they did was they identified an index case of somebody with Delta variant, and then followed 167 subsequent infections. And you can get it by going to virological.org, and hopefully it'll eventually come in the form of a peer-reviewed paper. And assuming it pans out, it tells a very important story, because what it says is that those who are infected with the Delta variant have 1,000-fold more virus quantitatively shedding than other lineages. And so this may be the basis by which this virus is more transmissible, because people are shedding so much more virus. And if that holds up, it kind of gives us a framework to think about this as a problem, because it helps explain the potential breakthrough cases of vaccinated individuals, because even if you have lots of virus neutralizing antibody, there's still so much more virus around that you are getting breakthrough infections, even though they seem to be either asymptomatic or mildly symptomatic. And it also explains how we have to think about going about wearing masks down the line, because all of the guidance that the Centers for Disease Control has put out about vaccinating people not needing masks were more or less based on the original lineage, or the UK variant, the B117, which made a lot of sense. And I agreed with their recommendations. But now, if it's true that Delta is being shed in so much more abundance by both unvaccinated and even vaccinated individuals, we may have to think about revisiting that. And that means that vaccinated individuals may want to think about wearing masks when they're indoors in areas of high transmission. And so that's another added piece of nuance here, is not only is the Delta variant behaving somewhat differently, it's not just a light switch. It really depends on where you are in what part of the country. So for instance, if you're up in Massachusetts or Vermont, where almost all of the adults and most of the adolescents, almost all the adolescents are vaccinated, transmission is just not going to accelerate. And it may be okay to follow previous CDC guidelines that if you're vaccinated, you don't wear a mask. But right now, for instance, where acceleration is really cranking up in Missouri and Arkansas, and it's going to spread all through the South, northern Florida is getting hit hard, you might want to rethink that and think about wearing a mask if indoors, if there's still lots of transmission. So I think this is, going to be one of the complexities of the epidemic as we move forward over the next few weeks and months. Is Delta will accelerate. It'll accelerate the most in areas where vaccination rates are low, and how you act, how you behave, how you manage yourself and your family through the epidemic may depend a lot on local transmission. In fact, the CDC did say that, but I think that kind of got lost in the mix. And I think this is going to be the toughest part is following where we're at in terms of the epidemic. In terms of Texas right now, we're not doing the worst by any means. We're still in the bottom tier of states in terms of COVID transmission. But once again, we're seeing kind of just like we're seeing two COVID nations, we're also seeing two aspects of Texas. So, for instance, along the border with Mexico, vaccination rates look pretty good. Same with some of the big urban areas, including Houston. We're doing relatively okay. But then you go into the rural areas of East Texas, up in the Panhandle, it looks like very few people are being vaccinated. So I think there's going to be a real vulnerability, especially in East Texas and the Panhandle area, that could start to look like Missouri or Arkansas over the next few weeks. And that, of course, has a lot of implications for the Texas Medical Center in terms of transporting patients and handling those potential surges. Overall, I think, even if that were to happen, perhaps one of the only silver linings is that because we're doing a little bit better on the older Americans, we probably won't see nearly the same level of deaths as we saw last summer in the Texas Medical Center. But we're still going to see a lot of young people get sick. And I think that's the other part of the narrative that needs to be fixed. There's this kind of buzz out there, in part engendered by the anti-vaccine groups, that says this is exclusively an illness of older Americans and those with underlying morbidities, and they make the statement that if you're young and healthy and go to the gym and take care of yourself, you don't have to worry about getting vaccinated. And it's not true. It's not a substitute for virus neutralizing antibodies. And so we will see lots of young adults get sick, maybe not necessarily lose their lives because if they're being taken care of in places like the Texas Medical Center, but they're still getting sick, and adolescents are going to be getting sick. And the rates of adolescent vaccinations in this part of the country are really bad. I mean, if you look at Alabama, Tennessee, Louisiana, Mississippi, and likely, I'm guessing, a lot of the rural areas of East Texas, we're looking at less than 20% of adolescents are being vaccinated. So that's going to be a huge vulnerability, not only for our Texas Medical Center institution, but also the children's hospitals as well. So that's something else that I'm looking at. And finally, we don't really understand the impact of long COVID in younger people. Clearly, the numbers in young adults are not looking good. We're seeing up to 26% of young adults get long COVID. We don't have good data yet on the adolescents and little kids, and that's something that I'm looking out for as well. So those are some of the big picture things that I'm thinking about.
Sure. Dr. Klopman, back to you. I want to ask you, we looked at data this morning which was showing that the average age of our COVID patients has dropped considerably. So we're seeing younger populations, the percentage of those populations are much higher, which is often when I'm in discussions with people, they feel, as Dr. Hostes says, that they'll just ride it out, they'll be fine. But now when we're thinking about this large mass of people being infected and their ability to infect others, share some of your thoughts or concerns in this.
Well, I think if you look at other countries, so look at Israel or even in the UK, it's the new cases in Israel are 50% older people who have, and then mostly the other 50% are young people who have not been vaccinated. So we're seeing a big surge in cases under the age of 20. 10 to 20 is a huge number in many other countries. So I think we're going to see the same thing here. There was an interesting study out in Norway. They just look at utilization of physicians in their pediatric population. And what they saw was in COVID infected kids, where they normally have an annual visit, they're seeing their physician 6, 7, 8 times, which speaks to what Peter is talking, this sort of long protracted illness that kids get. And so, it's not this whole concept that it's not a problem for young kids and teenagers is not a good idea. I mean, we don't want our kids to get this disease. But I'd say 50% of the cases being driven in other countries, and I think soon here will be, in unvaccinated adolescents. and of course in the unvaccinated adults.
Right. It's an interesting, another piece of data that came up this morning where we see that our emergency rooms are exceedingly busy of late, and this is even with non-COVID. And there's been, it was discussed that perhaps the fact that we've now dropped masks, mandatory mask wearing, we're coming together in large groups, 4th of July celebration, which we saw a huge fallout of that last year during just with the UK variant here. What do you predict going forward? We've spoken about this as fourth wave. We're seeing the mounting of it in the hospitals, the emergency rooms, and then our ICUs. What should we expect over the next month or so?
Well, it's interesting. Our discussion this morning, Mark Wallace is the CEO of Texas Children's, mentioned they'd had 1,000 RSV, respiratory syncytial virus cases in the last 3 months, sort of correlated with people stopping wearing masks. And so, we all predicted last year that our big fear was the terrible flu season combined with COVID. And what happened was, because of the mask wearing and social distancing, flu just didn't show up last year worldwide. I mean, just worldwide, it was a very, very weak season for flu. But now that we're back, we are all a susceptible population. As we get back together again, I think we're susceptible to a lot of respiratory disease, and people are people with sniffles are coming and go, oh my God, I've got COVID. It's, like a common cold again. So I think it's interesting to see. And there's a lot of pent up medical need. I mean, people have put off a lot of medical care for about 1.5 years and are finally feeling comfortable. And so our emergency rooms are filling up again, I think, with people who are feeling more comfortable going to the emergency room for care. So that was true in our county hospital, it was true in Methodist Hospital, it was true in St. Luke's. So the emergency rooms are getting busy again, I think, as people feel more comfortable without wearing masks, unfortunately.
Yeah, and I think, it's really quite interesting what's happening now that masks are coming off. It's respiratory virus time to party. So we're seeing, as Paul mentioned, this big increase in RSV cases, and we're seeing that across the state. If you go to the Texas DSHS website, you'll see a big increase in respiratory syncytial virus. What's surprising about that is typically that's a winter virus, and these viruses are pretty reliably seasonal, and so that was a bit of a surprise for me. I would have expected RSV, but later on, I wouldn't have expected to see it now, and therefore we shouldn't be surprised about a bad flu season coming up as well. We don't have much to go on because usually we look at what's happening in Australia in the southern hemisphere to predict our flu season, but because people have been masked in Australia, I don't think we really can rely on that. So we'll have to see. The point is get your flu vaccine. The other thing that I'm worried about is with all the social disruption, there was a big decline in childhood vaccinations, both things like MMR, measles, mumps, rubella vaccine for the little kids and human papillomavirus vaccine for cervical cancer, other cancers for the teenagers. There was a big interruption in those vaccination programs. Now they're starting to come back up. But I think the question that I'm asking right now, with all of the damage inflicted by the anti-vaccine groups, will there be collateral damage around the typical childhood vaccines for MMR, measles, mumps, rubella, and HPV? And will they come back to baseline? And I don't know that they will. And so I'm also holding my breath as kids get back to school about potential measles outbreaks that we saw in 2019. So that would be something else to look for.
Yeah. Dr. Hutchins, another follow-up question, and then I want to open it up to our colleagues in the media. We did a fairly good job of prioritizing and treating our most vulnerable populations, nursing homes and others, with the original outbreak. But as I've learned, is many people with compromised immune systems don't develop many antibodies. And so I'm now with the variant and people coming and visiting nursing homes not wearing masks anymore. could we see a potential uptick in our elderly community being affected by the Delta variant that do not have the ability, even with vaccinations, that we might see more breakthrough cases?
Yeah, I mean, we don't have a true correlate of protection for these vaccines, but there is some rough association with levels of virus neutralizing antibody. And there's some small studies showing that if you're, for instance, on immunosuppressive therapy, for instance, if you're a solid organ transplant patient on immunosuppressive therapy, or cancer chemotherapy or CAR T therapy or bone marrow transplantation, it looks as though those individuals in small studies would benefit from a third immunization. So I thought when the whole dust up around the Pfizer press release came out about the need for a third immunization, I didn't think it was necessarily warranted for most people at this time, but I thought there would have been some mention of those on immunosuppressive therapy and those of who are extremely old age, up in the 80s and 90s, who also may not respond. I think those individuals may benefit from a third immunization. So hopefully we'll get some guidance pretty soon. And the point is, we don't have a lot of time to mess around because now Delta is really accelerating. So if you're going to do it, don't wait, do it now. And I hope we get some guidance about that soon.
Great. Thank you. Diana, we'll turn it over to you and to our colleagues in the media.
Terrific, and thank you. And you can continue to submit questions through the Q&A and chat function. We'll start with a question about what has been called the beginning of the fourth wave. I think we've heard you say that hospitalization data shows that our hospitals have capacity to manage additional cases. Based on what we know about the Delta variant right now and the region's vaccination rates and the evolution of COVID-19, should we anticipate another potential surge that could potentially overwhelm our hospital systems?
Well, let me start off and then I'll turn to Dr. Klopman. I would say I'm speaking obviously of the Texas Medical Center. We were always prepared for that, and we're running right now in our phase one. We have 3 phases of ability to scale our operations up to handle patients, whether they be a culmination of both COVID and non-COVID patients. And so we're at 96% in phase one. When we were at the height in June and July of COVID, we never moved out of phase 2. So we never moved into our final phase 3. So we've got capacity, but that's largely, we're unique in the sense that we're often treating patients come here from all around the world. And so the ability for us to scale is quite different than a community hospital, for example. So we certainly see this wave coming. The one thing about what we do here is we aggregate the data in real time every day. So we're not waiting for reports to come out from a state or the nation. We're seeing this real time every day. We are also doing our testing in real time. So we have a better advanced warning system, if you will, for that. So we don't see ourselves getting overwhelmed. And I would also think that we're working with a smaller sample of people that having vaccinated. We're roughly at about 50%, shy of 50% of people that have had 1 dose. And I think we're at 42% in the state, people that have had just a single vaccination. So I think that the population is smaller, so I don't see us getting overwhelmed at all because we could handle this the first time through. But Dr. Klopman, or why don't you share your thoughts?
Yeah, so there's a lot of modeling taking place nationwide, and the Institute for Health Metrics and Evaluation out in Washington has been modeling the number of cases versus vaccination. And what they're predicting, I think, is, and we've been following exactly their prediction, is what we will see is a hill, not a mountain. We sort of saw 3 very big peaks in the past, and I think this one will be more of a prolonged, slow rise. It'll peak at much less than the peaks we've had before. But this virus is really good at finding unvaccinated people. So that, and we've only vaccinated half of the country and half of the state of, in our region, half of Houston. So we still have a lot of vulnerable people, and this virus will find them. And so we will have a continued rise for a while, but based on most of the modeling and what we're seeing, my guess is it will peak somewhere significantly lower than the peaks that we've seen before. So hospital capacity, we managed in the middle of the worst part of it. So I don't think hospital capacity will be a problem at all.
I think the big issue is going to be if you look at a place like East Texas, which is underperforming in terms of vaccination rates. As Paul says, this virus will seek because it's so highly transmissible, will seek you out. And we have to assume that a high percentage of the adults in East Texas, because they are unvaccinated, will get infected. Now, a little bit better in terms of older adults who are vaccinated. So what does it mean then when you're going to have thousands and thousands of people in their teenage years, 30s and 40s in East Texas get infected? And I'm not sure we really know. Even if some will certainly require hospitalization. So how much of a surge that will be on our system is an unknown. And then what the impact of long COVID is going to be in terms of neurologic sequelae, that's an unknown. I got very concerned when I saw this paper that's in preprint form come out of Oxford University in medRxiv, showing a lot of gray matter brain degeneration in people with and adults with COVID. And these were all individuals over the age of 40. And how much of that will extend to younger people, I don't know, but it's pretty concerning. I mean, the clinical picture looked a lot like the cognitive declines you see with aging or even Alzheimer's disease. So I hope that we're not going to see a lot of neurologic disability in young people because of Delta, but I think that's going to be one of the unknown questions moving forward.
Great. Dr. Klopman, can you speak to two topics? One, you mentioned the monoclonal antibodies not being effective at all against the Delta variant. And two, Dr. Hotez had touched a bit on boosters. Can you give us a broader picture on what we might expect in terms of understanding the regulatory environment for a booster and when and how we might know more?
Well, let's start with the monoclonal. So again, the study that was done was in vitro, not in people. They isolated a Delta virus from a family in India, looked at the ability of the monoclonal antibody to neutralize that virus, and it was ineffective in vitro. Whether that means it will not work in people, we don't know, but it sort of suggests that it might not. There's no data on this right now, so I think the practice of early infusion of monoclonals for people who are at risk probably should continue, but I think we will have to wait to see whether or not they, like what happened in the Petri dish, does it happen in people that it's not very effective? And that's a concern. It's not surprising. Monoclonal antibodies are very specific for a particular small region on the spike protein. And as the spike protein changes, you can understand why a monoclonal antibody would not respond. The difference about getting a vaccination to a spike protein is your body generates a number of antibodies to various parts of that spike protein. It's much more effective than a very targeted missile to one part of the spike protein. But it does suggest that the monoclonals will be less effective against Delta virus. So that is true. As for the booster shot, I think Peter's point's a good one. Right now, the CDC is recommending 2 shots, if it's Moderna or Pfizer for the mRNA vaccines, and 1 for Johnson & Johnson. They are effective, 95% against the UK variant, 85% against the Delta variant. And there's good evidence that you have prolonged antibodies at least a year, and there's now good evidence that you have memory T cells and also the cells that make antibody in lymph nodes also being very active for a long period of time. That would suggest you might not need a booster shot. On the other hand, if we continue to have variants that they continue to degrade the ability of the vaccines to be effective against that variant, then we may need them in the future. And there are subsets of people who are not responding, whether they're old or have immune compromised problems with cancer or other immunologic disease or transplant, those people may very well need a third shot and a booster shot. We don't routinely measure antibody levels in people, but when we see folks who, in some studies, there's a group of people who do not generate a big immune response. And so in those individuals, or in some situations, physicians might measure antibody response and then, do a third booster. But right now, the recommendation is not for that. It gets a little complicated if you've had AstraZeneca vaccine. I would personally feel pretty unprotected right now if I had AstraZeneca. And for whatever reason, it's a slightly different, it's the same spike protein, but the vector that provides the vaccine is different. It's an adenovirus from a chimpanzee. For whatever reason, it's not generating the same level of immune response, and that's a problem. And so we're doing a study now at Baylor and some other, it's a multi-center trial looking at a third dose of Moderna, no matter what your previous vaccine was, and looking at the ability to boost antibody levels and the importance of that. That's a national trial that's going on. I think the results from that will help dictate what we do in the future based on, what the results are from that study.
Terrific.
I think we probably, will need a third immunization down the line, as Paul says, to build in more resilience against the variants. The question is, when do you do it? The press release from Pfizer recommended doing it now for Delta. They did not present a very convincing case, except perhaps among selected populations. I think there's also the equity issue, given the fact that none of the rest of the world has much access to mRNA vaccines, and here we're already talking about a third immunization. So I do think a third immunization will come down the pike at some point, maybe later in the year or next year. The only question, other than the immunocompromised individuals and those of extreme ages, we'll have to see what the breakthrough infections continue to look like. One of the problems is CDC, Centers for Disease Control, is not monitoring for breakthrough infections. They're monitoring for breakthrough hospitalizations, but we don't really have a sense of the level of protection. So we're hearing a lot of anecdotes of people getting sick with breakthrough infections, but hard to know how significant that is. We know that the level of protection with the two mRNA vaccine doses is going to be between as low as 64% as shown in Israel and up to 80% or so as shown in the UK. Almost all of those are asymptomatic or mild infections, and hopefully that will continue to hold here, but we'll continue to follow it.
We have a number of questions that I'm going to group together about the fourth wave, the Delta variant, and individual and public health measures. So the questions include, should people return to masking and in what circumstances? Should businesses be taking additional precautions, both in terms of employees coming into the office and businesses like restaurants and retail thinking about capacity limits or mask requirements for entering the business? Is travel safe? And then we have some questions about school-age children, but we'll put those into a second bucket.
Well, there's a lot there. So let's start off. I mean, you mentioned kids. I mean, the biggest number of questions come with schools and the American Pediatric Society, just to, hopefully everyone will wear masks in class up to, in schools. I think that they're unvaccinated, and that's clearly what needs to happen. We'll see how that goes, but I think that should be a requirement for teachers to be vaccinated, all adults to be vaccinated in schools, and kids to wear masks. It's a hard thing. I was very disappointed in the CDC's quick take your mask and throw it away response, because that transferred all the responsibility to business owners. I mean, because they can't be the mask police. And if you're a grocery store, or let's take an essential service like a grocery store, and that not everyone is vaccinated, then your employees are at risk, and it's just it's not good. And since the CDC said, well, you don't have to wear a mask anymore if you're vaccinated, well, all the businesses were stuck with, please wear a mask if you're unvaccinated. So I do think right now, when you walk into a place where there's a lot of people and you can't tell who's vaccinated, I wear a mask. I still wear a mask when I walk into a grocery store. You know, and I would, if I were an employer at I would have my employees both get vaccinated, but also probably wear masks. And I think we're going to just have to see it. We may have to take a step back. The UK has taken a major step back. You know, they've rescinded a lot of their openings. They're reinstating mask wearing, et cetera. And I think we'll have to watch it. But I personally feel that you're at risk when you're around a large group of people who are unvaccinated. The best news about travel, and no one I think anticipated this, is there have been very few outbreaks from airplanes after the masking requirements went in place. Early on, there were many examples of people being infected in airplanes, long traveling distances, where no masks were worn. After the mask mandate, there really have been no clear outbreaks related to travel on an airplane. There have been plenty on buses, including the church outbreak that happened here in Texas. The original example of the Buddhist group in China that went in two buses. One bus was infected, one wasn't. Showing early on without a mask, it's very easy to infect within a bus. The church outing, no one was required to wear a mask. There was a giant outbreak because there were 2 hours in a bus. So in contained environments, there's very little ventilation with people who may well be infected. Mask wearing has been very effective, and not wearing a mask shows how incredibly infectious this virus is.
I would add to that, we were one of the companies that brought back our employees, but we had 100% vaccination. We're now starting to look at what that policy will be like now with the Delta variant, that we will probably be starting to move back into a masking scenario, certainly in group settings, maybe not individual offices, but you know, it's a numbers game. And with the opportunity, knowing not only that you can get sick, but if symptomatic, you're also spreading to your children, it becomes a larger public health issue than just the employees per se.
Great. And I think, Dr. Klotman, you answered the question about school children and the fall, but Dr. Hotez, I don't know if you had anything that you wanted to add to that overview.
Yeah, I think, again, it's going to depend a lot on local levels of transmission in terms of safety. So in parts of the country where everybody's vaccinated, except those who are not eligible, I think it builds in more flexibility and room for error than if you are in a place like in Missouri or Arkansas where nobody's vaccinated, and then you're going to see this very high level of transmission. So, you know, I'm worried about how things will go in some of the school districts in the South, you know, and a lot of the kids are going to go back to school next month, because not only are those schools have very low rates of vaccinated teachers and students, but they're more likely going to be schools where people are dismissive of masks as well. And we'll have to see what kind of level of virus transmission happens in the schools. The schools overall probably have done better than I would have expected over the last year, but all bets are off with this Delta variant because it is so much more transmissible. So I would not be surprised if the Centers for Disease Control revises their guidance, revises their guidance statements because of Delta, because Delta is like nothing we've seen before. It's got a reproductive number that's 6 or so. That's really, really high. It's not quite measles territory, but it's really getting up there. So hey, hold on, hold your breath. We'll have to see where this goes.
Yeah, and just to emphasize what Dr. Hotez was talking about, one of the key factors we forget is the level of virus in the community. We keep talking about, like, in a homogeneous country, we're 50% vaccinated, but it really does make a difference what the level of virus is in your community. So just to emphasize again what Peter was saying, in places where there's very low vaccination rates, and including the teachers, you don't have to guess what's going to happen. There will be outbreaks in those schools for sure. And in places that are highly vaccinated, they may get away with not even wearing masks. Hopefully they'll be more cautious and they'll get through it. But it totally depends. It's one of the reasons why one of the metrics we follow in the Texas Medical Center is number of cases per day as an index of how many people are being infected. And when we were all hoping for 40, we were beginning to be excited when it got down to 200, and now it's 500 again. So that's a lot of people. 500 and 100 hospitalizations per day. That is a huge amount of virus in our own community. So we still have a lot of Delta virus in Houston.
Yeah, and I'll add to that. One of the major concerns I have is testing was our radar, and it was the most accurate way where we could really track and understand the presence of the virus in our communities. And what has happened is, as you've seen, most of those testing centers that were supported federally and regions have shut down. There's still a few there, but they're very, very small. People have moved past testing. We've seen reduction of testing even in hospitals because people are vaccinated. They're not being tested. So we're really, as this new fourth wave begins in force, our radar is down. We have really a fraction of the testing. I'll give you an example. We would test 4,000 people a week in the Texas Medical Center. We're down to about 2,000 to now 1,000. So that's the visibility that we even have has really decreased. We're thinking about increasing that, but with the testing sites gone away, or think about in the community how often you'd speak to a colleague that would be tested often, and now that has dropped off. And so we're going to be running much more blind to the spread of the Delta variant in our community.
I mean, I think the heartbreak is assuming those numbers that say more than 95% of the hospitalizations are among unvaccinated individuals, what you're basically saying, except for the children who are not eligible, everyone who's now being hospitalized for COVID-19 is there by choice, is there because they chose not to get vaccinated, or for some reason they didn't have access to getting vaccinated. And I think these kinds of unforced errors are really scary. The fact that we could not, even despite the fact that we had great vaccines that gave high levels of protection, we were not able to persuade a substantial segment of the population to get vaccinated. I think this is something that we're going to have to keep in mind moving forward. The incredible damage that the anti-vaccine disinformation empire inflicted upon the health of this country. So first it was defiance of masks and social distancing. Now it's defiance of vaccines. And so this anti-science movement is a killer. And it's going to continue to cause lots of hospitalizations across the country.
Dr. Hotez, that actually relates to a question that we've received. Twitter recently suspended Congresswoman Marjorie Taylor Greene for violating its COVID misinformation policy. Why is it so important to crack down on misinformation, to have accurate information, to distribute it regularly from trusted sources?
Well, we've seen the damage that it inflicts, right? I mean, this, as I say, 600,000 people lost their lives from COVID-19, in part because of the SARS-2 coronavirus, but it was enabled by the defiance around masks and social distancing and now vaccines. And it happened because of intent. It happened because of three groups that went out of their way to pile on disinformation. And I've written about this now in the Daily Beast, and it's an article that came out yesterday. I call it the three-headed monster of the three heads of the anti-vaccine movement, which includes at least the major non-governmental organizations identified by the Center for Countering Digital Hate. It's amazing we have to have an organization called the Center for Countering Digital Hate that is putting out a lot of disinformation. Then we have even the Russian government, the Putin government, which is weaponized health communication, using this to destabilize the United States and other democracies. And then this political extremism on the right. And you heard this from Marjorie Taylor Greene and other far-right members of Congress, and you heard it at the CPAC conference. I mean, it's just just terrible things said about vaccines, and that has consequences. And you're hearing it from some of the conservative cable news networks at night. And we're going to have to find a way to tamp down that disinformation because it is causing an enormous amount of damage.
We've talked a lot today about the Delta variant. We've got a couple of questions about the Lambda variant. We've had one identified case at a hospital in the Texas Medical Center. What other data do we have about Lambda variant here in the greater Houston area? And what should we know about Lambda?
Dr. Klopman?
Yeah, so Lambda is this variant that sort of originated in Peru, and it's the dominant variant in Peru. It's considered right now a variant of interest, not quite a variant of concern, because we really don't know enough about it. Not surprisingly, considering our proximity to South America and Central America, that a case showed up, and Houston Methodist, and they sequenced some of their viruses and found this one Lambda virus. We don't know. We don't know if it's going to be, one like the Brazilian, the P1 variant that it was really bad in Brazil, but never really took hold in the US. I mean, it's here, but it's not the dominant strain. So we'll just have to follow it. We don't know. But right now, it's not known whether it's either more infectious or more virulent, but we will just have to follow it.
Yeah, it looks similar in some ways to Delta. So with Delta in the 452 position, there's I think it's a leucine to an arginine, whereas in the Lambda, it's a leucine to a glutamine. So it's going to be probably some similarity. For right now, Delta is the dominant variant, and that seems to be sweeping through the country right now. So I don't think Lambda will be a big issue in the immediate future, but down the line, wouldn't surprise me if that takes off again as well. And again, this may be a reason why, with this new reality because as good a job overall as we've done in the US, we've done a terrible job globally, right? Nobody's vaccinated on the African continent for all practical purposes. And we're not doing much better in South America. We're not doing much better in Southeast Asia. And we're going to pay a price for that as variants continue to evolve. And that may be the reason why we do that third immunization down the line.
Two closing questions. One, is there an opportunity to shift the future of the evolution of this virus if we could speed up, both in this country and globally, expanded access to and uptake of vaccinations? And two, given what we know now, do we have the opportunity to stay ahead of the curve on the future evolutions of this virus and continue to update therapies and vaccinations in hopes of not having the kind of chaos that was caused at the outset?
Well, the answer to that's clearly yes. The virus mutates every time it replicates, and so, or if you prevent replication of the virus, you prevent the development of mutations. And so getting ahead of it, if we were able to vaccinate, and that's why it's so important to consider other countries, because anywhere where there's a hotspot, variants will form. So making sure South America, Southeast Asia, Africa, Mongolia, these places that are really hot, having outbreaks, have to have their viral burden lowered, and they're preventing the virus from replicating in those communities will prevent the development of variants. I mean, that's the whole goal. And the key is getting enough people vaccinated, and that's the problem. So Peter, I think, said it very well. We could do this. The sad part is we haven't, but we could do this if we got 85% of the country vaccinated, even within our number around 6. That would probably be enough to bring it down to very, very low levels, and maybe even disappear. But we're not going to be able to do that until a large part of the world, 85 to 90% of the world is vaccinated. But you can look at smallpox. It's doable. I mean, we've done it before, polio, almost polio, but we've had worldwide success when there's a focus on doing it. So you can just look to the success of eliminating smallpox as an example of where you can eliminate a virus if you vaccinate enough people. We just haven't had the will politically, societally, however you want to do it. We just haven't been able to get our country aligned to do it. And as Peter said, even if we got our country totally vaccinated, 100%, there's always the concern that there's emergence of variants in other parts of the world. And so, as we talk about the third shot, we ought to be thinking about the first and second shots in Africa and Argentina and Peru and Chile and all these places.
Yeah, I mean, I do think, I agree. I think we can vaccinate our way out of this pandemic, but we have to vaccinate, and we're not. And, this is why, at Baylor College of Medicine and Texas Children's Hospital, we've developed our low-cost recombinant protein vaccine at our Center for Vaccine Development that's headed by myself and Dr. Mary Elena Batazzi. And this has now been licensed to India, and India's and now put in an advanced purchase of 300 million doses. So we're excited about that. And hopefully it'll be released for emergency use later this summer. We've also now licensed this to Indonesia through Biopharma and to help with their terrible epidemic that's going on now with Delta variant. The failing has been the G7 countries. They've not really taken ownership of this issue and recognize the simple fact that when you've got 1 billion people in sub-Saharan Africa, 650 million people in Latin America, and 500 million people in the smaller low-income countries of Southeast Asia, that's 3 billion people, and we need 6 billion doses of vaccines. And no one ever did that back of the envelope calculation to say, hey, how do we support and make 6 billion doses of simple, easy breezy, durable COVID vaccines to deliver to the world? And we're trying to come in to fill that gap and trying to work with the United States government, but it's been very frustrating because they've not wanted to take ownership of this global problem. What the Biden administration is doing is focusing on optics, doing some patent waivers here and there, which won't have any impact, or at least in the near future, or saying they'll donate 200 million doses of Pfizer-BioNTech this year, or 60 million of AstraZeneca. I don't want to say it's a drop in the bucket, but it's extremely modest when we simply have to manufacture and distribute 6 billion doses. And it's not that expensive. I mean, we think our vaccine could be made for $1.50 a dose. 6 billion, but India's already taking on 1 billion doses. So the other 5 billion, could be shared among the G7 countries. It's a rounding error in terms of what we've been spending so far. So I think that's where we have to push harder.
I agree with that, Peter.
Well, thank you to our 3 participants today and for all of the media who have participated. As Bill has said in the past, you play an important role in sharing accurate information with the community about the steps that they can take to protect themselves and each other. And so we appreciate your participation and continued distribution of accurate information.
Thank you,
We'll
Dr.
be sharing
Klopman.
video.
Dr. Hotez, thank you very much for your time and the tremendous work you've done throughout this pandemic. We really appreciate it.
Well, thank you, Bill. It's a great honor to be here with you. And thank you, Diana. And thank you, Dr. Klopman.
Thank you, guys. Appreciate it.
Have a good day, all.
Yes.
Bye.